Next, we have Michael Brauer. I'd be surprised if any of you don't know him, at least having read about him. He is amazing and one of the people that continue to inspire me to try to make my own work applied. Mike has been inspiring me for decades. He's a professor at the School of Population and Public Health. He's also getting increasingly involved with the IHME in Seattle and the global burden of disease, which many of you know about. I don't know that his talk is about it, but you can learn more about that if he doesn't speak to it. One of the things I think is noteworthy about Mike is how he's increasingly been asked by global institutions, they're listed in the program, for his advice. It's proof of his expertise and also the respect that people have, and we're all very, very lucky to have him here. One of the things he's done, and he's going to talk about now, is low-level emissions. The idea that we've made so much progress, and yet we haven't still found that ability to get to a level where we've reduced health effects maximally. So we're not quite there yet. Mike, please come up, and thank you for covering this really important topic.
Thanks, Chris, and real pleasure to be here. I realized, even though I think I've helped organize the meetings for the last 5 years, I haven't been to one, so it's nice to actually be here. So the purpose of this talk is really twofold. One, I think, is to acknowledge and really celebrate the improvements that we have made in air quality in most high-income countries in the world, including in Canada. But also to tell all of you that the job is not over, and it probably will never be over. The more we learn about air quality and its impacts on health, we understand now that poor air quality is incredibly deadly. And I think I've spent my whole career trying to convince myself otherwise. I've always been very skeptical, but it's really, the evidence is really, really mounting and really very strong now that poor air quality is incredibly deadly. So I'm going to talk to you a little bit about a study that we've worked on actually for the last 6 years or so across Canada. We're taking really large samples of the Canadian population based on our census, so this is fully representative of the Canadian population, with the goal of really trying to understand what are the health impacts of air quality at the very low levels that we have in Canada. And as Chris mentioned, I do a lot of work in a global context. Our air quality is really good from a global perspective. Air quality our air is clean here, but it's not actually clean enough. And what we're learning from this study is that we will always probably see health impacts from air quality as long as we have dense populations as we do in our urban areas. So this project is part of an effort from the Health Effects Institute to really understand the health effects of low levels of air quality. We know that our air quality, as I mentioned, has improved over recent decades in high-income countries, but we're starting to see, and we started to see that, especially in our work in Canada, health impacts at these low levels. And this is sort of a recurring theme. I'll point out when I went to graduate school a long time ago, I actually said to my supervisor, "Why study air quality? This is over." And that was the stupidest thing I ever said. Well, maybe not the stupidest thing, but I could probably have said that last year, and I'll always be wrong about that. But we actually had very limited evidence at the very, very lowest levels of exposure that we see in countries like Canada. Canada is a perfect country to actually study this. You can see from this plot that the most recent WHO air quality guidelines, and I helped work on those, for PM 2.5 are at a level that's extremely low. Most of the standards that we have, including the air quality standards in Canada as well as in the US, are above that level. You can take those WHO standards as sort of a non-political, these are health-based guidelines, and what I'm going to show you now is actually we're detecting health effects even below those levels. So there's been this massive decrease. I'm going to talk mostly today about PM 2.5, but we actually have the same issues for nitrogen oxides, and particularly in this context of transportation. That's going to be very challenging for us to meet as long as we have any combustion-fueled vehicles in our cities. So getting down to the levels of the WHO guidelines for nitrogen oxides, I think is going to be extremely challenging, as it is going to be for PM 2.5. This process was basically taking the evidence and looking at what do we know and where do we see health impacts from all the studies that have been done around the world. I think it's quite unlikely that these guideline levels will ever be lowered further. It really becomes quite silly, and really we're talking this is what we did is actually took all the studies in the world, took the lowest sort of levels from the studies, kind of averaged a number of those, and that's where the guideline levels come from. Most of these studies, actually the top 5 in there are actually studies from Canada, and then 2 US studies, and we basically just took the average of the lower levels in the studies where we were able to detect adverse health impacts, and that's where the guideline values come from, and the same thing for the other pollutants. So we're probably left with a situation of continuous improvement of air quality, and this is actually a Canadian concept that we've had in our air quality standards and guidelines for many years, that it's not about meeting or not meeting a standard, it's about actually improving year on year on. And if you... Okay, all right, sorry about that. And really, I think the idea of trying to meet a specific guideline is sort of an old approach, and we really should just be looking at improving each year by X%. And if we do that, we'll be most true to what we understand in terms of the science of the health impacts of air quality. So this is sort of the keeping clean areas clean concept, again, that's been part of Canadian air quality management for many years. So this study that we did, and I'll just point out, we took a sample of the Canadian census, so the 20% of the sample who fills out the long form census. There's probably many of you who have done this. This is where you get all these sort of detailed questions. These samples are then linked to death registries, and we also link them to income tax filings. This is all anonymized. I don't know who anybody is. These income tax filings actually tell us where people live and where they move every year, so we can track residential histories over lifetimes and then follow these individuals through the death registry and see actually when they die. It's, again, very representative of the population, but we have only limited information about individuals in terms of other risk factors. So we complemented those populations, and you'll see we had one wave for each census. So it's several million people for each census. We pool it all together. It's about 7 million Canadians that we looked at. Then we complement that with a population from the Canadian Community Health Survey, which is a health survey that is more voluntary. It's still quite representative of the population, where we have a lot of information on other risk factors, so smoking, diet, sleep quality, physical activity, etc. Because we're trying to get the very, very lowest levels, we need to also go beyond our cities to our smaller communities and our rural areas, which still, that constitutes about 20% of the population of Canada. And in order to do that, we need to actually go beyond where we have air quality monitoring sites. So we use really complex methods with satellite-derived estimates, which are linked in a complex sort of statistical framework with the ground monitors that we have. In order to really tailor this to Canada, we did our own additional monitoring where we co-located basically the reverse of satellite sensors, so we can look sort of up to space, the same way a satellite looks down to ground, combined with air quality samplers, And in order to better understand how the relationship between what a satellite views and what we see on the ground, and basically tweak those estimates specifically to get at this sort of context in Canada. I won't go into sort of the details of this, but basically what you're seeing on the left is sort of before we did that tweaking, on the right is afterwards, and we reduced the error, improved the agreement between what we estimate from the satellite and what we get from ground monitors. On the upper left, this basically shows us a trend of concentrations across Canada over the last, I guess, 30 or more years. So we've seen this massive improvement. So we again take this and combine it with the residential histories and assign these exposures to individuals based on where they lived at a particular point in time. But again, good news here, and you can see we have this really strong and massive decrease in pollution over time. And this is just another way of showing it, looking from the 80s to sort of the 2015 and onward. You can see just the profile. This is, again, at the resolution that we're estimating, so at a 1 kilometer resolution across all of Canada. Really these massive improvements in our air quality over this period. We also adjust for the context, so we're really comparing people who live in cities to other people who live in cities in a particular part of the country to other people in the same part of the country, and really trying to adjust for all kinds of other factors that might influence your lifespan or your longevity. And so I won't go through these in too much more detail. So what are the results? And all I'm showing you are these hazard ratios. So this is the increased risk of dying for a 10 microgram per cubic meter increase in PM 2.5 concentrations over either a 3-year or a 10-year period before the point of death. And we see both the short-term exposure, so relatively close to when individuals died, as well as sort of more lifetime exposures. Both of those are actually quite important. So we see a 12% increase in mortality from all causes in this Canadian Community Health Survey, and the second line is a sort of a 9% increase. That's after we add all of those other risk factors. So we're really not that sensitive to whether or not we control for smoking, diet, physical activity. That actually doesn't matter too much. So we sort of attenuate those estimates a little bit if we take all those other factors into account. And the reason I'm showing you this is because in the larger population, in those census-based surveys, we don't have that information on individuals. But what this shows us is that even by not having it, we're not really having biased estimates, or not biased by too much. This is showing you now for those census-based cohorts, again, pooling everything together, so 7 million individuals, 25 years of follow-up. So this is really one of the most extensive studies in terms of population and length of follow-up and detail in terms of understanding exposure that's ever been done in the world. We should be actually very proud and thankful that we have this resource in Canada. This is a national resource. It's actually open to anyone to actually do this kind of analysis. And you can see now by cause of death and the causes of death that are important. And most of the causes of death that we looked at, cardiovascular and respiratory, we did see increased risk of dying in relation to air pollution exposure. One sort of surprise here, and I really do not have an explanation for it, is that we don't see an increased risk of death from lung cancer. That conflicts with many other studies that we've done in Canada, as well as that have been done elsewhere in the world. But again, I really don't have an explanation for why we consistently actually don't see this in this analysis. Very complex here, but what I'm showing you is actually how do we model what the relationship looks like. So all of those numbers that I showed you before are just assuming kind of a linear relationship. But we know that the relationship between air pollution and health is nonlinear, meaning that you get different rates of increase at different levels of concentration. And that's important because that tells us about the benefits that we may get from reducing air quality. So if that relationship sort of flattens out, you get sort of a less benefit, let's say going from 20 to 10 than you might get from 10 to 5, where it's very, very steep. And what we consistently see here, and this is very complicated to model statistically, but what we consistently see here, and you can sort of see this at the bottom, is that when we go from very, very low to sort of the next highest level, it's very, very steep. And as you sort of get to higher levels, things tend to flatten out. And this is just another, well, I'll come back to this actually. So what do we find? We find, again, very similar to in that Canadian Community Health Survey, we see about an 8% increased risk of dying for a 10 microgram per cubic meter increase in PM 2.5 concentrations. This is also attenuated if we add ozone or oxidants, which is a combination of ozone or nitrogen oxides, to our analysis. So there's actually, we don't think that this is ozone per se, but we think it's something about the character of the air pollution that is better characterized by ozone than it is by PM 2.5. So what does it mean from a practical sense is that even though we see health impacts from PM 2.5 very consistently, we still need to measure and control these other pollutants and the sources that contribute to this. We also looked at how this varied regionally across the country. I think that's what, I can't actually see this, what this is showing, I think. Oh, this is actually, again, for ozone, so sorry. What we're seeing here is that the shape of these relationships, and they get very noisy, but we really only see very consistent relationships at the highest levels of ozone. So the effect of PM 2.5 is strongest when ozone is also quite high. So again, there's something about the mixture itself. So we simplify our lives and we simplify our control by thinking about this on a pollutant by pollutant basis, but we really need to think about this as a mixture. And that mixture is complex and we really don't understand it very well. And I would say we probably will never understand that perfectly. So, yeah, I think I'll just move on from here. This is looking at how these things vary regionally. And much to our surprise, we saw that there was actually regional variation across Canada, in that there were parts of the country that we basically saw sort of two phenomena. So you can see in the upper right and the lower left, two parts of the country where we still get an increase when you go from the very, very lowest to the next highest level, but then there's a range of particle concentrations where actually things sort of tend to improve or there's sort of no effect, and then things sort of take off again. Meaning that there are probably conditions, and we've looked at the populations, we can't explain this by differences in population by region of the country, access to healthcare, we've looked at everything we can possibly think of, and it seems to be something about the character of the air pollutant mixture in the different regions of the country that we get these different shapes of the relationship. Again, all of them we see this increase from the baseline to sort of the next kind of highest concentration that we can measure, but we also have this range of conditions where there doesn't seem to be anything going on. Again, speaking to probably different sources, different mixtures, sort of having different potencies across the country. Other regions of the country, it's almost a linear increase or goes up very sharply and then sort of tails off at the highest concentration. So we're exploring this a little bit more, but again, I think it speaks to the importance of characterizing air pollution as a mixture and reducing all of its constituents. So just to wrap up, we see these consistent associations between particulate matter concentrations and non-accidental mortality, as well as cause-specific mortality in this very large cohort that's representative of the population. These are unlikely to be confounded by behavioral risk factors, and we see this at very, very low levels of exposure, a minimum effect level, which is really the baseline that we can see of 2.5 micrograms per cubic meter as a 10-year average. So again, thinking about that means over 10 years of your life, that's your average and we're now probably sitting in a condition in Vancouver where it's probably 5 micrograms per cubic meter on a pretty clean day like this. So again, the message here is that our jobs will probably never be over. And then of course we have the added challenges on top of this with climate change, which is going to increase wildfires. It's going to increase the production of ozone and oxidant pollution because of the more active chemistry that we're going to have, or we do have in a warmer climate. These are driven by the major causes of death in Canada. Canada, like most high-income countries, is we have an aging population where we're increasing the prevalence of chronic diseases that are affected by air pollution. So that's heart disease, that's stroke, that's COPD. So even if we tread water, even if we stay the same, the health impacts of air quality are going to get worse just because of the aging of our population. So again, climate plus the demographics add to our challenge. I don't want to depress you again. We've done a lot, but our job is not over, and that's really why we're still holding this meeting today. And actually, I've sort of said this to myself, why are we still doing this? Like, look, the air quality is beautiful. It's pristine out here, but, much to my surprise, we still see these health impacts. These associations varied regionally and were attenuated by ozone, and it's unlikely to be due to the population characteristics. We have these pollution mixtures. And most importantly, there's really no evidence of a threshold. So that even again in those regions where we sort of saw those weird shapes, when you go from 2.5 to 3, you actually see an increased risk of death. So there's really absolutely no evidence of a safe level of air pollution. So suggesting that continuous improvement, the benefits of continued reductions in exposure are important. And again, that's why we're here today talking about things like other sources of air pollution, for example, from brake and tire wear, that are going to persist even if we completely electrify our fleet of vehicles. We also sort of looked at what this means in a global context. And we basically took sort of the current situation on the left, and which is assuming that there's sort of no impacts on health below a World Health Organization guideline of 5 micrograms per cubic meter. And then if we took our information, which is sort of the distribution on the right, we're adding globally about another 1.5 million deaths. And most of those deaths occur in high-income countries. So even though of the 4 million or so deaths that we see from air pollution every year in the world, most of that's dominated by low-income countries, especially India and other countries in South Asia. The job is not over for the high-income countries of the world. And in fact, this is just showing that on the y-axis, the percent increase in mortality as a result. On the x-axis is mean concentration. Everything that's clustered on that left-hand side, those are all high-income countries. So if we sort of take the information that we get from this study in Canada and apply it to the world, it's actually the high-income countries in the world, again, because where are we assuming that there's a safe level or no effect level, that's where we see this massive increase. It's something like a doubling of the impact of air pollution in Canada, depending on whether we're saying that sort of 5 micrograms or 2.5 or so is safe. So again, the take-home message is that our job, unfortunately, is not over, and we'll probably see you back here next year. So I will close with that and be happy to answer any questions. Thank you.
Great presentation, Mike. So my question is actually going to be completely unrelated to high-income country context and low pollution context. I was really intrigued by the nonlinearity of the PM 2.5 effects and the different shapes of the curves at different ranges of PM 2.5. So thinking about low-income countries where like there's all these household air pollution interventions, and a large degree of them don't show a significant effect in terms of health benefit, but you see reductions in PM 2.5 is what's commonly measured. So is there thought about, perhaps this non-linearity where, you can have a reduction in household air pollution in a home or in a community of homes, but, you're seeing the reduction in these ranges of the distribution that, where the steepness of that curve could be shallower, and therefore the public health benefit, when you think about it in linear terms, is not being seen. And there could be other things that explain it, and I'm keenly aware of those, but what are your thoughts on that?
Yeah, so you're asking about kind of the higher end where things tend to flatten out, and so if you move from here to here, you might not get a benefit. So first of all, just to point out, this is on the population level, not on the individual level. There is some evidence that same thing occurs for individuals, and that actually makes sense. So if you think about, if you get sick, you get sick. You can't get sicker and sicker and sicker and sicker. Or if you put it more bluntly, you can only sort of die once. You don't get to die harder and harder and harder. But from a policy perspective, I think it's probably a combination of the populations and sort of the exposure setting. So if you make those reductions, let's say, and not seeing an effect, well, you probably haven't reduced things enough. That's kind of the obvious answer, that it's still bad enough. And again, we sort of see that in a context like Canada. So like Canada, if you took Canada and put it anywhere else in the world, that would be like your goal of trying to get there. And of course, what we see in Canada is, that still kills Canadians. And mind you, we've done actually studies about immigrants to Canada as well. So let's say people who come from very polluted settings and then come to Canada, it still kills them. And so there's complexities here, but I think that could be a reason. And of course, if you want to get to the low levels, you also have to go reduce the high levels. What we're trying to sort of sort out is whether there would be one source or not that would be better to reduce. And to the best of our abilities, we haven't been able to crack that nut either. We haven't been able to say, reduce, let's say, mineral dust, reduce transportation. What if we reduce one before the other, do we get more of a benefit? We really don't see any difference. So not a very satisfying answer, but
Thanks very much for your talk there. That was great. So my question is related to those plots as well. My first question is, what is the averaging period for the PM 2.5, whether that was 24-hour, annual, or 1 hour? And my second question is, because of the steepness of the health risk increase at lower levels, is that suggestive that we need lower ambient air quality standards and objectives?
So most of what I was showing you was a 10-year mean. We've done it for a 3-year mean or even a 1-year mean, but it's sort of a 10-year of 24-hour measurement. So it's really long-term exposure. We don't get much of a difference actually if we go to 3-year or so. But and in terms of do we need standards? So I kind of think standards have become silly now. So the U.S. now is debating between 9 or 8. Or 10, or, I think it's actually a joke because we actually can't even measure those differences. What I would advocate for is we should look at where we are this year and, maybe we can adjust it for weather and let's try and reduce it by 5% every year or 10% every year and actually change our thinking about it because we're getting to the point where, we're close to background. And so it's a sort of a signal to noise issue. And it takes a lot of time and resources, so we spent 6 years in WHO going from 10 to 5. I don't want to spend another 6 years, going from 5 to 4, and then have all these countries that are at 30 and whatever, let's just get it cleaner, right? It's pretty simple.
Yeah, that was a just brief follow-up on a comment you just made, Mike, about PM 2.5. Does any of that work, can we use that to say that PM 2.5 total still remains a good predictor of health effects, and we don't need to move to looking at PM 2.5 toxicity or speciation or composition, or does it tell us the other way around?
So I think as much as, and it's a fantastic question, as much as all of us believe that the toxicity must be affected by the composition and the composition of sources, still, PM 2.5 itself is the best indicator. So again, even though we saw these regional differences, we still see those impacts. But it does mean that their air quality is different in different regions, and I think we need to understand I wouldn't say the composition, but the mixture. So let's say, for example, in our region now, throughout much of the summer, our poor air quality is dominated by wildfire smoke. So 20 years ago when I started, looking at this, there was a lot of belief that wildfire smoke, it's wood, it's not hazardous. We now know that it definitely is. We're really not seeing any difference, and if anything, it's more harmful than kind of the typical air pollution mixture. And when we do that for other contexts, we see exactly the same thing. So we spent many years, dealing with countries in the Persian Gulf saying, this sandstorm, this dust isn't toxic. When we look at it, yes, it is. So it's all bad. And it probably is wherever you are, whatever those source mixtures are bad. So I think what we know is if we reduce PM mass concentrations, we see health benefits. And that's probably should be, again, our goal for management.
All right. With the changes you mentioned in the mixture, would there be an annual, if the PM 2.5 changes in mixture because of the climate change and more wildfire happening, would there be a change in the shape of the profile of the health effects of PM 2.5? And also, did you see the seasonal variation, like if summer or wildfire season, the curve will be different compared to during winter time when it's a different source mixture of PM 2.5?
Yeah, so all of this is looking sort of over longer, at least a year. So we did not look seasonally at all. And I'll just sort of answer your question in a little bit of a different way. When we look at air pollution and health in a different way by looking at daily changes in air pollution, let's say daily counts of deaths, certainly in where we are right now, a lot of that's dominated by a wildfire smoke episode. But the impact of air pollution on that sort of daily basis compared to the longer term average is about 10% or so. So the long-term exposure is much more harmful than those daily changes. And our question, and I don't think we have an answer yet for something like wildfire smoke, which we tend to think of as an episodic event, is now becoming less so. So if all of us are now exposed for 2-3 months every year to some level of wildfire smoke, which is sort of becoming the way it is, and if you're in California, that's exactly the way it is, is that a long-term exposure? And I don't have the answer to that, but my sense is yes. So all of what I showed you is just going to translate. And what wildfire smoke is going to do is kind of, erase some of the improvements that we've seen because of all the air quality management that's been so successful. So, it goes back to what I said earlier, climate change is going to make the job that we have to do more challenging, unfortunately, but it gives us all work to do.
Don't go away yet. This could be in a couple minutes. Can you talk about you showed that, I think you showed it said that the PM effect was greater at higher ozone levels. And you said we don't know why, which is okay, but it seems to me intuitive, unless I'm misunderstanding, that at higher ozone levels, biologically, you're going to have a more oxidating effect on the airways and the rest of the body. And so it just stands to reason that the PM effect is going to be in an environment of what I just said. So that's not, I mean, it makes sense, right?
Yeah, and when we actually look, and I didn't show it, wasn't part of this study, but Scott Weikenthal at McGill has done a lot of work at looking at the oxidative potential of the particulate matter mixture, and that explains a lot of that regional variation that we've seen. So that's something about the character of it. But we do also see that sort of oxidant. We can't actually tie that oxidant potential to specific sources necessarily, or even to specific meteorology. But yes, so it is biologically, it makes sense. Yeah.
Do they know that stuff he's doing, Scott, is really cool? Do they know much about the oxidative potential of fire smoke? And it's sort of a separate thing, but I'm just curious.
So yeah, I'm not sure Scott's looked at it, but there have been studies in Southern California that have looked at it, and it has high oxidative potential, but for different reasons than the rest of the air pollution mixture. So it's sort of organics versus metals. Yeah.